Three, two, one. What's up, everyone? Dr. Michael Moeller here with the Michael Moeller Mentality. Welcome to people who have been here and new people. And I'm super excited today. I have my good friend and colleague, Dr. Drew Timmermans here, aka the Regenerative Performance Man. What's going on, Dr. Drew?
Hey, how's it going today? Doing well.
I'm happy to have you, man. So we got a lot of things to cover today, especially from just words like regenerative medicine. People don't even know what that is. But first, I want to, we'll get into stem cells. I want to get everyone kind of hyped about all that stuff. But I think we need to hit some bases here. So you're a naturopathic medical doctor, correct?
Yeah, in Arizona.
So can you give people your elevator speech? Like, hey, what is that? What's a naturopathic medical doctor, right?
Yeah, so the way I typically tend to approach that question, because we obviously get that asked quite a bit, is so our philosophy for medicine is just slightly different than the current conventional philosophy out there, in the sense that we have the luxury of spending a bit more time with our patients because we're outside of the insurance model in a lot of places. And so because of that, we tend to create a deeper connection with our patients and help them along their healing journey. And that extra time that we spend really allows us to try and figure out why patients are having the symptoms they're having. Why does their back pain hurt, or their back hurt and they have low back pain, as opposed to just saying, well, you have low back pain, let's get an MRI and then let's schedule you for PT or to go see the ortho and for a surgical consult. We get the opportunity to learn more about our patients and to dig into the different layers of health and disease and figure out, why is this happening? What else is happening in your life? Oh, you also have diabetes that can, exacerbate your pain, or you also have hypertension and all this other kind of these moving parts for the whole host of a human. And so I think that's really how I tend to just describe naturopathic medicine. Personally, I use a combination of herbs, supplements, and pharmaceutical medications, because I'm a big believer in every single facet of medicine is a tool, whether it is Reiki to hypnotherapy to straight up surgery to regenerative injections. Everything has a tool. Just like if you walk into, a shop, like my dad back home in Canada has like a wicked shop out in the back, because his side business is he owns a cremation urn company, and like there's tools in there that he uses like once a year. But when he needs that tool, that's the tool he uses, because the other stuff doesn't work. And if you try to use something else, it doesn't give you what you're looking for. And it's justified to have that tool, because when you need it, it's appropriate. And that's kind of how I envision medicine as a whole. And so I refer for surgical consults frequently. I refer to psychotherapy and counseling when appropriate. Just because I don't do it doesn't mean it's not right. And so I'm just a big believer in that medicine is just different tools that need you, and the skill of the physician is not in applying the therapies they know to the patient. It's figuring out what tools this patient needs, and then if you have that tool, you use it, and if you don't, you refer out. So that's my philosophy on medicine.
And your brand name is Regenerative Performance, correct?
That is correct.
So go find him on Instagram. Go find him. You're on YouTube. Been watching some of your stuff and following him for a while. He's popping out a lot of good information. What's regenerative medicine then?
So regenerative medicine, the ultimate goal from my standpoint is to help a patient's body to regenerate itself. Some patients, or some not patients, but some people view regenerative injections and regenerative medicine as, oh, I'm going to go to the doctor, he's going to inject PRP into me, and that PRP and the doctor are going to regenerate my injuries. But when you actually start to even look at like the science of how PRP or bone marrow, like mesenchymal stem cell injections are working, it's so fascinating to me, because it's just a relocation of stuff that was already in that patient's body to another area that then triggers their own innate healing response so that they heal their supraspinatus tear, or they heal the cartilage that is, degenerative in their knee, and that's helping their pain and function and stuff like that. So within the scope of regenerative medicine, I don't just look at the actual injection therapies like prolotherapy, PRP, exosomes, stem cells, but also like, how are your hormones? I mean, if you don't have enough androgens, if you don't have sufficient testosterone, your rate of degeneration is going to be much, much greater, than the rate of regeneration. And
Amen.
so you're just going to just keep degenerating. And so it's looking at all that kind of stuff, even if soft tissue work or hormones or nutrition and lifestyle. And so even though I don't just practice injections, what I practice is regenerative medicine, because I just want to help people feel better, which usually takes some form of regeneration.
Mm-hmm. Dr. Drew, you were talking something about stem cells. I thought stem cells were illegal.
Oh, you want to get into that talk now?
Yeah, man. I thought you can't be doing that. What is this guy? Is this China? You practice in China?
Oh, down in Panama. All right. So within stem cells, so we have to be careful anytime we talk about that, because what happens in the US is different than what happens in other countries. So you can go to China, you can go to Japan, you can go to Panama, and you can get a legal live mesenchymal stem cell injection where they take stem cells from a umbilical tissue that's been donated and screened and ethically sourced and all that kind of stuff. And they can grow them in a lab, expand them out into, anywhere from 20 to 100 million live mesenchymal stem cells and give that back to patients as a treatment.
What's mesenchymal mean?
So mesenchymal is going to be the specific lineage in the body that's going to then derive. So from that mesenchymal stem cell, you can derive adipocytes, you can derive osteoblasts, so bone cells, tendon cells, muscle cells.
That's the ones we want.
Yeah, so that's the ones that in our body really facilitate the healing of our connective tissue, our bones, our muscles, our tendons, nerves, things like that. Okay. And so that's all legal outside the US.
Okay.
Within the US, though, the FDA doesn't allow the expansion of stem cells and then the transplantation into another human. So really what they allow is autologous, which means your own stem cells. Autologous means yourself. Allogeneic means other. And so they really only allow autologous stem cell procedures. But even within that, there's some different criteria that need to be hit. And it basically boils down to, how are your listeners in terms of, if we get into some nitty gritty?
Yeah, I mean, I'd say throw it on there, and I'll do my best to answer that or ask the questions that they would ask. Does that make sense?
Perfect.
Yeah.
So in order to be classified as a procedure, there's certain criteria that the FDA kind of says that you have to hit in order to not be considered a drug. And so the easiest way to talk about this, I guess, is to look at adipose. So within adipose, there's a portion called stromal vascular fraction.
And adipose is fat.
Adipose is fat, yeah.
Okay.
And so within the fat, there is a layer that you can isolate called the stromal vascular fraction. The clinics that do adipose stem cell IVs that are actually coming from the own patient are using what's called stromal vascular fraction. Mm-hmm. In that, there's a rich supply of mesenchymal stem cells. And
you're telling me I can get stem cells out of my fat?
Yeah. Fat is actually one of the most abundant places that you can get stem cells from. Second most abundant being the bone marrow.
But and you're saying people basically go into their fat, pull out stem cells, and then put it in an IV?
Yeah.
And then put it in their blood. Okay.
Yeah, there's some processing steps that have to be done to remove some of the things. I mean, the fat as a general rule needs to be removed from that IV because that can cause a fat embolism and can kill the patient. So there's obviously risks with that. So you just have to process it specifically. But yeah, you can take stem cells from the fat and give it back as an IV, except for the FDA considers that a drug.
That's in the United States only, right?
That's
There's like, what's it called? Minimally manipulated is the term, right?
Yeah,
Basically what he's saying is you can't take these things and put all kinds of magic in it before you reintroduce it into the body. You basically, like you were saying earlier, you have to take something in one part of the body and put it in the other, and then everything's quote unquote fine as of now.
Yeah, that's correct. Okay. So with the adipose, though, you can take adipose, not add the specific enzyme that's called collagenase to the fat, which that's how you get the stromal vascular fraction. So if you remove that step, if you just do a liposuction, so you take someone's fat, you spin it in a centrifuge, you get rid of the oils, which are going to be really inflammatory. Mm-hmm. You can then inject that back into the different areas of the body, the joints, into the muscles. You can even do facials with it. You can do fillers with it.
What's the benefits of that? What does that do?
So there's still going to be stem cells in those fat transfer products.
Okay.
And so that's going to help to signal the other stem cells and progenitor cells, which are basically like precursor cells to, the tendon cells, the muscle cells, the cartilage cells. And the stem cells orchestrate this beautiful, beautiful symphony of events that results in healing for the patient.
Oh, cool.
And so tying that back into, what I was saying earlier about my philosophy on regenerative medicine is even when we do these, what could be considered a stem cell transplant, because we're basically taking stem cells from the bone marrow or adipose and putting it into a joint or into a muscle, the stem cells that we inject into those areas is not actually those stem cells are not becoming tendon cells. They're not becoming cartilage cells. They're telling and orchestrating. They're like the conductor. They're saying, all right, everybody, you guys are not doing your job at regenerating. So I want you to do this. I want you to do this. You go grab this other stem cell from the blood, bring him in, and let's get this healing going. And so it's really orchestrating the host, the human, to regenerate, which is why it's so beautiful.
That is awesome. Yeah. And I think that's a common, like what you're basically saying, a common misconception is people think, oh, I take these stem cells and inject them into my joint space and they become cartilage. What you're saying is when you inject it, it's telling the body to regrow in that area.
That's correct. Yeah. Okay. Yeah.
So, and then you were talking too, there's a difference. You can get stem cells from your fat and you can get it from your bone marrow. Mm-hmm. What's the difference? And why would you do either of the, is there a difference between them? And
so on the chemical makeup of the stem cells, there are some slight differences. And the theory right now, which is loosely supported in the research, is that the stem cells in the bone marrow are going to be a bit better suited to, and I'll qualify, anytime I say stem cells in the bone marrow, I'm referring to mesenchymal stem cells. There are hematopoietic stem cells, which are the stem cells that then turn into red blood cells, white blood cells, and everything else in your blood. But for our discussion for musculoskeletal, we're talking about the mesenchymal stem cells. Okay. So the literature loosely supports that the mesenchymal stem cells in bone marrow might be better suited towards cartilage regrowth and things like that, just because they're signals that they carry on them or might already be preconditioned to that lineage. Whereas the stem cells that are found in fat cells and adipocytes might be more programmed along that line, but still they're able to differentiate in a petri dish into the different varieties. But there might be some subtleties, but at the end of the day, they both contain mesenchymal stem cells.
Cool.
Now, go ahead.
No, I was just going to ask what you use them on, like what conditions, and if you had something else you can finish, and then we can get into that.
Oh, I was just going to say that on average, there are more stem cells in an adipose tissue than in bone marrow.
Is more better?
It sometimes is, in the sense that if I have more stem cells to use, I can treat more areas.
Okay.
But once we kind of reach what is considered a minimum effective dose in a certain joint, then having double the amount of stem cells in that particular injection may or may not actually improve patient outcomes.
Okay, so kind of like a diminishing return. Like, well, we got
Yes.
him. And what do you? I've heard about cell counters. Are those worth doing? And you said earlier that people were able to grow them, right? Like you might get a couple million when you pull them out, and then you can put them in what's the word for regrowing them?
Like culture.
Yeah, right. But that, like, we can't do that in the United States. It's like 24
Correct,
hours,
yeah.
or what's the deal with that?
It kind of gets into a real gray zone. I mean, even to get the product that you would need from the adipose to then culture it, you've already added collagenase, so you've already broken the FDA's rule. So
okay. But that is possible outside the United States to get, like, if I did a bone marrow thing, which kind of sucks. Those procedures aren't all that fun. And, but a lot of people are culturing them to get more cells so they can use them later.
Yeah.
Isn't, you can't do that in the United States right now, but
that's correct.
There's still ways around it, kind of like what you're doing, right?
Yeah. We can still do in-office same-day procedures, especially with the bone marrow. The FDA doesn't really have an issue with that because it's done in office. They've been doing bone marrow transplants for oncology, for cancer for a really long time. And so they know it's safe and all that kind of stuff. And so, but it's the new branches of regenerative medicine that they're just a little concerned with.
It makes sense. It gets, we're dealing with people's safety here. And I think there was a terrible case there was an ophthalmologist in Florida that injected stem cells in a guy's eye, or in some, there are some people, so make sure that you vet the practitioner before you work with them.
Yeah.
So,
definitely.
So what are some of the reasons that you use stem cells, and what do you see in your patients?
So in my practice, the biggest thing that we're treating is degenerative joint conditions. And so that's going to be your osteoarthritis, but also things like long-standing rotator cuff tears or tendinosis, anything from like golfer's elbow or tennis elbow. Mm-hmm. Basically, how I approach it is if there's an area of the body that has degenerated, then we want to use a regenerative therapy in order to help reverse that to a certain degree, or at least delay the progression and delay the rate that joint is degenerating. Mm-hmm. And so one of the frequent things that I see is patients coming in saying, well, I have, grade 3 osteoarthritis in my knee, which is on a grading scale, it goes up to grade 4. So they're pretty severe and quite a bit of pain, but they're not a true candidate for a total knee replacement yet. And so they come and they say, well, my doctor says I need to wait until this gets worse before I get a total knee replacement. And they project it'll be anywhere from 2 to 3 years. What can we do in the meantime? And I'll say, well, we can do a PRP or a bone marrow stem cell treatment.
What's PRP? We didn't cover that.
Oh, PRP is platelet-rich plasma. So what that is we do a blood draw. So it comes from your own blood. We draw your blood, we spin it down in a centrifuge, and we extract out the layer of plasma that is rich in platelets and other growth factors. The platelets, when they are re-injected back into a damaged area, when they get re-injected, they get activated. And when they get activated, they basically explode with a whole bunch of growth factors that then help the healing process. Some of those growth factors help with inflammation. Others help with growing new blood vessels, which is obviously going to be beneficial in bringing in more oxygen, more nutrients, getting rid of more waste products. And then some of them are chemoattractants, which basically means they, through a chemical gradient, will attract other stem cells and growth factors to the area to help healing. So,
because platelets, those are what cause clotting, right?
Yeah.
So when you get cut, platelets are what come and they heal that area. So you're going into the blood, taking that, and like you said, there's other growth factors, and shooting that into places of degeneration.
Yeah, well, with the ultimate goal of regeneration. Yeah.
Well, what's the difference between that and stem cells then?
So obviously the PRP procedures don't have any live stem cells in them, and so the treatment effect is weaker, although I don't like to say weaker because PRP treatments are really powerful at helping patients who don't have serious, long-standing chronic degenerative conditions. And so usually PRP actually is my first go-to before stem cell procedures, just because they're much more cost-effective in patients who are not at the extreme of their condition.
Okay.
So if someone comes in with grade 1 or 2 osteoarthritis, so basically mild to moderate, I'm looking at doing a PRP procedure, because for the money, that's where they're going to get the most bang for the buck. Mm-hmm. Whereas if we start looking at grade 3 and grade 4 osteoarthritis, then that's our basically our severe to really severe arthritis. Those patients the PRP just isn't going to have a strong enough healing response for them, because they're so degenerative that the stem cells tend to work better and is more cost effective at that point.
Is there going to be a difference then in, like maybe an old person, a young person, a healthy person, a non-healthy person in their platelets or in their stem cells?
Yeah.
You see that?
Yeah, both. And the other thing that really factors into all this too is nutrition. So you could have someone who's 30 years old, but who eats fast food all the time. And when we pull their blood and we spin it down, the plasma layer is cloudy, which tells us that there's a lot of fat in there, which is the triglycerides. And that can be an issue because the triglycerides can be slightly inflammatory when we inject that back into a joint, but the platelets also aren't going to function as well. And so on converse side, we could have a 70-year-old woman who she's been eating off her own ranch for the last 40 years, and she could have beautiful blood, beautiful platelets, and have a really great healing response. So age doesn't always factor in the way you think it would. It's more so nutrition and lifestyle choices that are going to massively impact the quality of stem cells and platelets.
So nutrition is a big deal. What about like smoking, drinking, other type of, maybe are there any type of medications that affect the stem cells or the PRP?
Yeah, so in terms of medications, any of the aspirin, which is a non-reversible platelet inactivator, we have to stop patients who are on aspirin before doing a PRP procedure. And I prefer it even for a bone marrow procedure, just because the platelets are not going to respond and we're not going to get as good of a healing response as we could. So as long as it's medically safe, and they're not taking it for, specific medical conditions that it would increase their risk of clotting, for example, if we were to take them off. But that's one of them. And then in terms of, smoking and alcohol, both of those are known to dramatically inhibit stem cell function. And so both of those are going to be really massively detrimental. But at the same time, we've also had patients come through who are smokers and they're not willing to change and they still want the procedure. And after, talking to them about that their outcomes are probably not going to be what they'd like, they still get a response, which the human body is phenomenal. They still get a response out of PRP, but our estimations are they're probably getting 30% of what they could, because smoking is going to decrease the amount of blood vessels we have in our body. And that's actually where a lot of our mesenchymal stem cells that are not in the bone marrow or the fat, that's where they live. They live on our blood vessels. And so with smoking, we get a decrease in the total number of circulating mesenchymal stem cells. And then the alcohol is also going to affect them and inhibit their function. And so those are probably the two big things that we counsel patients on beforehand, is alcohol and smoking.
Cool. Well, and what's interesting is in our medicine, we kind of have that philosophy of meeting the patient where they're at. Right. Like, so, every patient's going to come in at a different vantage point. And that's what I liked earlier when you were talking about nutrition, herbs, pharmaceuticals, Reiki, whatever it is. Our job as healers is to figure out a way to help our patient. Right. So I think that's something that when you talk about what kind of makes us different than other practitioners, is that in itself. Like I try and tell my patients, like, look, I'm going to tell you my recommendations. And but I realize that sometimes if I tell you, you're going to go ketogenic, you're going to run 10 miles a day. You're going to do this, this, and this. Like there's not going to be compliance. So you can run into, like you're saying, like, I want to help heal your joints. You need to stop smoking. Maybe they won't. It's like, well, I'm going to do my best, but I can only do so much to help your body heal. Right.
Right. Yeah. Yeah.
So I think that's something that's a big takeaway from that. So do you work on these other areas as well, as far as nutrition? How do hormones affect, stem cells and PRP?
Oh,
Cortisol,
massive.
Yeah. Dr. Drew, do you do cortisol injections?
I do not do cortisone injections.
What? How come? They're so good for you.
Well, I will caveat this. There's a time and a place for them.
Yes.
And I have done them in the past.
Okay.
But the indications for,
well, what's the difference between cortisol and stem cells? They're both good for your joints, right?
Well, they both can decrease pain on a temporary basis. But the cortisol is just basically a massive anti-inflammatory punch that just shuts down inflammation massively, which in a small subset of times, that it can be the catalyst to the patient having a healing response. And so I've seen this several times, and through my residency, saw this a lot because my residency director was an MD, and he still took insurance patients, so he did a lot of steroid injections. And patients who have an acute flare-up of, for example, a sacroiliitis, so a SI joint dysfunction causing massive amounts of inflammation. Sometimes you get so much inflammation in that joint that the positive pressure from that inflammation stops healing factors from coming from the blood into the joint. And so the joint is now in this chronically inflamed, unable to heal position.
Wow.
In those situations, a steroid injection can be enough of a catalyst to shut that down and allow healing of the joint to occur. There are some setbacks with that, though, as it's been very well documented in the literature that steroid injections are detrimental to soft tissue and cartilage, and that they actually increase the rate of degeneration.
Oh.
And so in those cases, I still like to, if I get a patient out of pain with a steroid injection, is we then look at, okay, in several months, we're going to do a PRP injection because we need to offset some of the side effects that we had from that, because I don't want to increase the risk and the rate that you get arthritis. But aside from that, the steroid injections don't actually directly trigger any healing, whereas the stem cell and PRP injections actually do. And so that's the big difference in them. And what I always tell my patients is, if one steroid injection doesn't get rid of your pain, stop. Because if one doesn't fully get rid of your pain, 10 isn't going to, 40 isn't going to.
Yeah, you see that, right?
1,000 isn't going to. Yeah, see way too much of that.
Nice. Okay, well then where do hormones come into play with this? Because there's I talked about testosterone quite a bit. I feel like there's an epidemic / conspiracy of dudes levels just plummeting, that plays a big part into being able to heal, right?
Yeah, and so there's actually receptors on the mesenchymal stem cell for both estrogen and testosterone, and both of them are beneficial in the differentiation and regeneration of those mesenchymal stem cells. Wow. And so even for women, in terms of making sure estrogen levels are high enough, but even in men, and my thinking, and I don't know your take on this topic, but my thinking on aromatase inhibitors and dropping estrogen.
I don't like it.
Men, good.
I don't like it, man. No, I don't like it at all.
Yeah, even and outside of the stem cell aspect of it, I mean, the bone issues you have with it, the cardiovascular issues you have with dropping estrogen way too low, based off a lab test that actually probably isn't even the best lab test to use, right?
The immunoassay.
Yeah, no one's running the sensitive, and so everyone's just tanking testosterone or estrogen that's probably already tanked. That
was a mistake I made kind of early on. Here recently, I've been listening to a lot of, I don't know if you follow Jay Campbell.
Yeah,
he's a great. I just got his book in Testosterone Optimization Therapy, and I listened to some of these OGs who've been in the game for 20 years. And luckily for me, I can listen to their mistakes, especially about that. That's been a big controversial area of testosterone replacement for a lot of the people that have listened before. When your testosterone goes up, it has a chance to turn into estrogen, and people think that's bad. I personally now, and this is something maybe you can back me up on, I don't treat numbers. I like, that's one thing people are like, hey, Dr. Michael, my numbers are here. Would you treat me? And I'm like, well, how do you feel? Right. And the same thing with thyroid, same thing with a lot of these conditions. Again, what makes this, I think, a little bit different is listening to the patient and not treating their lab work, treating their patients. Like, how many people come to you and say, hey, my lab or my imaging was fine, or my imaging said something. What's your opinion? How do you handle those situations? Like, what's your opinion on imaging? Do you always get imaging, never get imaging, or?
So I rarely get imaging for most conditions. The exceptions to that is if I'm ever going to do if I suspect a herniated disc and I'm considering doing a caudal epidural with whether it's 5% dextrose or a PRP product or a stem cell or exosome, anything like that. I need an MRI for that, just because if there's a full herniation, you can actually worsen the herniation with doing a caudal. So, and that's whether it's a steroid or an exosome, it doesn't matter what it is. There's certain times when with a herniation that if you do a caudal epidural, you can actually harm the patient. And so if I suspect that, that's one of the reasons I'll get an MRI. Most of my stem cell procedures, I have patients get imaging, not so that I can treat based off the imaging, but I just want to make sure that I have all my bases covered, especially when patients are coming in paying several thousands of dollars and making a large financial, emotional, physical investment to heal. I don't want to potentially miss something that could pop up in 3, 6, 9 months, and the patient think, well, they didn't get an MRI and I had a tear the whole time, even if the tear wasn't causing them issues in the past. But if it now starts to cause issues because I've resolved other things, I want to make sure I at least treat that stuff as well. And so my stem cell procedures, I do get imaging just to make sure I'm not missing anything. But outside that, 90% of the time with my patients, I'm not getting imaging because it's not going to change how I treat the patient. Because the hour of talking with them about their pain and the anywhere from 15 to 25-minute physical exam with my hands, that's what tells me what needs to be treated. Because, and actually I just posted about this on Instagram, and it got a bit of backlash, but if you imagine taking a picture of your dog, that picture of your dog doesn't tell you if your dog recently shit in the house. It tells you what type of breed the dog is, roughly maybe how old the dog is, but it doesn't tell you certain things about it, and you can't make an inference. Whereas with an MRI, it's the same thing. The MRI can show you, are the vertebra aligned? Is there a bulging disc? Is there a tear? But then people then translate that to, oh, if there's a tear, there's pain. And that is definitely not the case at all. If you took MRIs of, and this has been done a lot with low backs, but if you take a patient population that's over the age of 60, that is pain-free in the low back, and you take MRIs of their low back, half of them are going to have degenerative disc disease and other findings that people think immediately cause pain. And that's just not how pain works. Just because you have a structural change on MRI doesn't mean you have pain. And so because of that, imaging, really doesn't change how I'm going to treat most of my patients. And so I don't subject that to, financially or even the time constraint or anything like that. And so it's definitely running it very little.
Yeah. You dropped another word in there that we didn't define yet. You were talking about exosomes. What are exosomes?
Yeah. So when a stem cell goes into an environment, it senses its environment that it's in. And because a stem cell is like the great communicator, the great conductor, it needs to tell the other cells in the area what to do. And so just like you're actually, side note, I went and saw A New Hope at the Phoenix Symphony.
Oh
So
yeah.
like they had the actual symphony do the whole score for A New Hope.
That's
Dude,
cool.
mind blowing. It was amazing.
Yeah.
So anyways, just like the conductor uses his hands and his little magic wand to tell everybody what to do and how to stay in rhythm and all that jazz, the stem cell needs a form of communication to the other cells in its area. And it does that through what's called its secretome. And one of the things that it secretes is the exosome. So the exosome is basically a small little package of proteins and peptides, as well as mRNA and microRNA. That little package is the output of the stem cell. So the stem cell, as an example, senses a very inflammatory environment. And it senses that through the different chemical mediators that are in a joint, for example. It senses that and goes, okay, this area, we need to calm down inflammation. So I'm going to package up all these things that are going to tell other cells to ramp up their anti-inflammatory mechanisms. And then I'm going to send that out. And then that exosome gets absorbed by the other cells in the area. And it has the message to be like, hey, why aren't you being anti-inflammatory? Upregulate your anti-inflammatory proteins. And that's how the stem cell orchestrates the healing in that environment.
Okay, so why would you use that instead of stem cells or PRP? Or do you use them together?
I personally use them together. It's very rare that I will use them separate. The only time actually I will use them separate is if I'm doing an IV. So if I'm doing intravenous, exosomes can be really beneficial. Just because we're not able to do stromal vascular fraction, the stem cells from adipose tissue as IV. And so exosomes can be beneficial for that. But in terms of joint injections or tendon injections or ligament injections, I always pair exosomes with PRP or the bone marrow stem cells.
Okay.
And the reason why is because the current market of exosomes, so they make the products on the market, what they do to make those exosomes is they take stem cells, they stress them in a certain way, and usually they stress them with hypoxia or low oxygen levels. They stress the stem cell, they force the stem cell to make exosomes, and they collect those exosomes and make them into a product. The stem cell is able to sense the environment.
Wow,
the exosome, cool. The exosome is not able to. So when you get an exosome treatment, if the proteins, mRNA and microRNA are designed or have been programmed for inflammation, but they get put into a joint that is not inflamed, but is very degenerative, then you're not going to get as good of a healing response, because now you're telling the other cells in the area, hey, ramp up your anti-inflammatory proteins, and they do, but there's not a lot of inflammation there. So
inflammation can be good, right?
Yeah, it definitely can be, and it's needed for healing. And so sometimes it's not the right signal for the masses, for what is going on in that joint. And so there's a limitation in the current exosome market. Okay. Now, I believe that exosomes are going to be massive in the next 5 to 10 years. And what I think is going to happen is that we're going to start taking samples of patients. So we'll take a synovial fluid analysis, and we will have exosomes created for that patient.
Wow, that would be cool.
And I think that's where the power, especially in the patients where they might be 70, 80 years old, and so their stem cells aren't as robust as they were at 30. And so the exosome products could be really beneficial. But again, it really needs to be patient specific and patient tailored, which is why you hear stories, and I don't know if you've heard this, but patients come like, yeah, I had an exosome injection and it didn't really do anything. Well, it's like, well, either they injected the wrong place because they treated you just based off your imaging, or the exosome product wasn't the right exosome profile for what's going on with your condition.
Oh, so it seems like very individualized.
Yeah, yeah,
Exosomes.
yeah.
Well, and then we didn't even talk about the stem cells. We talked about autologous, meaning coming from ourselves. There's a lot of these new products coming out that are umbilical and amniotic.
Yeah.
Do those have stem cells in them, or what's going on with that?
So this ties back into our FDA discussion. So
Okay.
within the eyes of the FDA, there's two different paths that a product like that could go down. It could go down the product line of a tissue product, which is called a 361, or it can go down the line of a cellular drug, which is a 351. Now, the FDA has certain criteria that you have to hit in order to be called a tissue and not a drug. And one of those big criteria is that you can't have live stem cells in that product.
You cannot have live stem cells.
Cannot have live stem cells in that product.
Oh, okay.
And so to my last looking, which was within the last 3 months, there are no products in the USA that have been approved by the FDA as a live mesenchymal stem cell product.
Mm.
That means that every company on the market has registered as a tissue, and in doing so, they have told the FDA, we have no live stem cells.
Oh, okay.
Because if we did, the FDA would turn back around and say, oh, so you have live stem cells. Okay, you need to file a new drug application, an NDA, or an investigational new drug, which is an IND, because you just told us that you want to transfer live mesenchymal stem cells from one human to another human, and so you need to be a drug. And so all of the companies that are on the market right now have told the FDA, we have no live stem cells, but then they turn around and they tell the doctors, the reps, and the patients, we have live stem cells.
Yeah. Mm-hmm. I've been in one of those talks.
Yeah, but if you look at it's the International Society for Cellular Therapy, the ISCT, in 2000, it was either 2001 or 2006, but they released what is currently accepted as the criteria to define a mesenchymal stem cell. So this is the criteria that is now used in research in order for researchers to prove that the research they're doing is on mesenchymal stem cells. And there has not been a single company on the market who has ever actually hit that criteria. So no one out there has ever proven, yes, we have live mesenchymal stem cells up to the standard of what is needed in research. And in my eyes, if you're going to claim something's a live mesenchymal stem cell, you better have the backing to show it. Definitely. Because safety and efficacy for sure, but also the whole FDA aspect. But no one has ever been able to quantify and actually show that in their end product. Now, some companies will use shady tactics where they will show that data and say, yeah, we have live mesenchymal stem cells. Here's the criteria. But that criteria was done on the, for example, umbilical cord tissue before they added a preservative that is known to kill stem cells, before they cryogenically preserved it, and then before the physician thaws it.
Okay.
So they go, yeah, we have stem cells. But then at the end of the day, there is no stem cells in that final product. And so it's
are those still good products to use though? Like if I had an amniotic stem cell injection into my shoulder, is that dangerous or?
Not dangerous. There was one company. Can I name the company?
Sure, I guess.
Livion. So
yep, I know that. I talked to one of their reps. They're getting some heat right now, right?
Yeah, so they had a contamination issue with one of their batches of umbilical cord tissue, and so they got a lot of people sick because of that. So on the danger side, there's that potential risk of contamination. But outside that, it's not dangerous to receive those injections, except I personally find it dangerous to mislead patients into thinking they're
Yeah.
getting one thing, and in reality, they're getting something different.
Well, I see people do that for the price point, right? Because when you're talking
yeah.
about doing like a bone marrow aspiration, that's a whole, can you walk just a quick kind of walk through when someone wants a bone marrow aspiration, stem cell injection, the difference in that, and like the other stuff already comes in a tube and you can just put it in your syringe and you shoot it in the shoulder. Where with the bone marrow, what, you're laying someone down for a couple hours and.
Yeah, so patient lies on their stomach. We will visualize the posterior iliac crest. So basically part of your hip bone, low back
You do
area.
that through
MRI, either ultrasound or
fluoro.
fluoroscopy.
Okay.
Yeah. Right now I'm doing it under ultrasound. So we visualize that. We identify the location that we want to enter into the bone marrow cavity.
Mm-hmm.
Then we will numb up the bone with 4% lidocaine, which is a very, very strong anesthetic to make sure the patient is as comfortable as possible for this procedure. Then we'll use what's called a bone trocar, which is basically just a large needle, and we'll enter into the bone marrow cavity. We will extract out the bone marrow. Most of the time, I'm extracting from both hips, from both sides of the patient in order to maximize the number of stem cells that we get. And then from there, the bone marrow goes into a centrifuge. We have a two-spin process that helps us to isolate out the stem cell layer that is also rich in platelets and other progenitor cells, and then minimize the amount of red blood cells that are in the final product. And then we re-inject that back into the areas that the patient has pain under ultrasound and or fluoroscopic guidance.
Okay. And how long does that take?
So the extraction, once we start the procedure, the actual extraction takes 8 to 15 minutes. Sometimes patients have really thick bone, and so it takes a little bit longer, but usually we're done that in about 15 minutes. Processing time for the bone marrow is anywhere from 30 to 45 minutes. And then after that, the injections can range from 10 minutes up to an hour and a half, just depending on how complex of a case we have and how many different injections we're doing. So on the short end, we're looking at about an hour and 15 minutes. On the long end, upwards of 2.5 to 3 hours.
Okay. So it's a little bit different than someone just blindly taking an amniotic stem cell fluid and shooting into a shoulder. But exactly. I see people change, the price points, like you said, is a couple thousand, thousands, depending on, the procedure. So
yeah,
it's the way people are getting a good dollar out of it.
Yeah. So to answer your question on efficacy, so the amniotic fluid, umbilical cord, placental matrix, those products are still beneficial because they have growth factors in them that are powerful at helping with inflammation, stimulating some of the stem cells that are in the patient already to kickstart some healing and that kind of stuff. And so they are beneficial from that standpoint. But what I found is these clinics where they only do an amniotic fluid injection, for example, more patients than, how do I word this? Compared to my practice, and this is not an ego boost thing because my success rates are on par with the other physicians who are doing the same therapies that I'm doing. But our success rates are greater than the one-stop shop clinics where they're getting 2 cc's of amniotic fluid injected into them. Mm-hmm. And the reason why is a volume issue. So if a patient comes in and they have shoulder pain and they get an x-ray, because let's be honest, it's usually chiropractic clinics that are running these one-stop shops. I love chiropractors, nothing against the profession, just everything against the one-stop shop chiropractic clinics who are just banging out injections for patients.
Yep.
They'll take an x-ray and they'll say, oh, your shoulder joint is degenerative. That's where your pain is coming from. Go see my nurse practitioner and they will do the injection. And then they get 2 cc's into the shoulder joint. Mm-hmm. And in some patients, their pain generator was the shoulder joint. Mm-hmm. So they get better because of that. In other patients, just because, again, back to the imaging stuff, sure, they have degenerative joint disease and they have osteoarthritis in the shoulder, but their pain was coming from their supraspinatus tendon and their subscapularis tendon, and they have a little bit of subacromial bursitis. That's where their pain is coming from. They come back to like, I'm not any better. And the doc's like, we just need to do a second treatment. And they're like, okay.
Here's $10,000, 15 more $1,000, you know?
Right. And it's like, so anytime I add in a product, whether it's exosomes, placental matrix, amniotic fluid, I add it into a PRP or a bone marrow treatment as a boost.
Okay.
And so I have enough volume with the PRP or the stem cells to treat everything that needs to be treated in this patient. But now they've just got an extra growth factor boost from the product. And that's how I use those products. Okay.
And then we talked a little bit before the podcast started about peptides. I'm just now getting in this myself. I was lucky. I did a podcast with Ryan Smith of TaylorMade.
Oh yeah. Great guy.
Yeah, man. He knows his stuff well. And so I've ordered a couple bottles myself. Have you gotten to try out some of the BP-157? That seems like the hot one, man.
Yeah. BP-157 is, so that one came across my radar probably 4 years ago or so.
I had friends back home, like I'm from Illinois, and I remember being in clinic one night and they're like, dude, what's this BP-157? And I was a little ego crush. I'm like, dude, I know this stuff. I'm the regenerative medicine specialist. You don't know anything. And then I was like, it's probably garbage. And then I go online and start reading this stuff, and there's some research on rats and their stomach. And I was like, dang, this stuff looks pretty legit.
Yeah. It's really fascinating. So clinically, I use it quite a bit for both my patients in pain, but also my GI patients. Any patients who come in with
it orally, like through the capsule or just through the liquid?
So I just started using the capsule the last few months when I got set up with TaylorMade compounding. And actually I just had a follow-up phone call with a patient just today, actually, where this dude has had, what sounds like a stomach ulcer and a small intestine ulcer all at once. Basically, he gets burning pain when he eats food, and he gets burning pain when he doesn't eat food. He has had every workup possible by his gastroenterologist. He has tried every conventional treatment. He has tried a whole host of alternative treatments that have just not helped him at all. He started oral BPC 4 days ago, and he's at like a 40% improvement so far.
No way. That is so cool, man.
It's so awesome. But
that is crazy.
But clinically, what I've seen with the oral is that oral does tend to work a bit better for GI conditions than the subcutaneous. But for musculoskeletal conditions, both oral and subcutaneous seem to work about equally well.
So you're just like, if I have a shoulder issue, obviously you're evaluating and trying to find the source of pain. And then you just do a couple cc subcutaneous around what you think is generating the pain, or?
I know some docs do that. I personally haven't seen a big difference in doing that compared to just having the patient go home with the bottle and injecting it every day subcutaneously into their abdomen or their glutes.
Insulin. Oh, okay. Yeah. So you're not even doing it around the site. You're just doing it.
Yeah.
Interesting.
But the other thing that clinically that I've noticed with it is the body takes BPC and it heals what it wants to heal, not what we want it to heal. And so if patients come in and they've got GI symptoms, but also shoulder pain, and we give them BPC, their gut stuff gets better and their shoulder doesn't change. Like, this doesn't work. I'm like, dude,
your gut. That's cool.
And so sometimes if we're really wanting the BPC to massively impact the shoulder joint, for example, we either just stay on long enough that it clears through the gut and then gets to the shoulder, or we do other stuff for the gut first. So that way, because it is pretty pricey, so that way when we spend the money on BPC, it actually ends up healing the shoulder that we want it to. But it's just managing patient expectations. But the body just does what it wants, and it heals what it wants to heal.
And I went on the forums, I went on the internet, and I had a friend, and I do not support buying these things online from research purpose only places. Like Dr. Drew and I both get our stuff from a compounding pharmacy out of Kentucky, which means that they go through rules and regulations to make sure their stuff is safe.
Yeah.
That aside, I had a friend who self-diagnosed himself with carpal tunnel and went online and bought it liquid and actually squirted the liquid in his mouth, so it didn't do capsule. And he said that his carpal tunnel went away.
And I believe that. And actually, a lot of the research studies that were done in rats was they took the injectable form and they either did the injectable form orally, or they did it intraperitoneally, or they did it sub-Q, or they did direct ligament injections, or they did a nerve hydrodissection around the sciatic nerve.
Whoa.
Yeah, really, really cool stuff. But it appears that the route may not matter as much as some people think, but I have seen a better response now that I'm using the capsules in my GI patients.
Well, isn't that kind of how the stem cells work too? Especially, I don't know, can you do them IV? But I've heard that when you take IV stem cells, they have a tendency to go where they need.
So
I don't know.
in the US, technically, so this gets into a deeper convo. So in November of 2017, the FDA released what they called their draft guidance, which was basically a draft, like you're writing your essay, it's your first draft. They basically released, hey, this is what we were thinking for the legality. The legality around stromal vascular fraction IVs. So technically, it is not illegal at this point. There are still many clinics who are doing it. But the problem is what they said is this draft guidance is going to end in 3 years. So in November 2020, we are going to have a final version. And knowing the FDA and government stuff, it'll probably be a few years after that.
Yeah, it's not coming out this fall.
No, but what they said was that this gives you guys 3 years to collect your data, to present us the data that you have. And again, this is tailored towards bigger, hospitals, educational institutions, that kind of stuff, to say, hey, you have 3 years to collect your data to show us that this is safe and effective, and maybe we'll consider having it be legal. But the small clinics, whether it's a naturopathic doctor or a medical doctor, they're still doing these therapies, but not collecting data. And the FDA could show up at the door and say, can you show us some of your preliminary data? And if you don't have it, then you could be sanctioned and shut down.
Okay.
So it's easier to just say it's illegal, because in reality, the only way you can get it in the eyes of the FDA and it be legal is to enroll in a study at basically one of the major hospitals, or, like Stanford has a study. I believe UCLA has a study. Pretty sure Harvard has a study. And so all the big academic institutions have SVF studies that you can enroll in because of the draft guidance, and they're collecting data for the FDA to try and keep it legal. So.
Okay. Interesting. Have you looked at any of the benefits of IV stem cells? I know people going to Mexico and Panama and doing them.
Yeah, so a lot of systemic benefits. So the patients who are going to respond much better to the IV stem cells are going to be the patients who have systemic conditions. So usually it's neurological. So patients with MS, ALS, Alzheimer's, Parkinson's. There's some interesting research not done in the US, but in Panama with Neil Reardon's clinic down there, or over in Japan or China, that they're getting positive clinical outcomes with the IV stem cell treatments. But also patients with chronic lung conditions, COPD, asthma, things like that, are responding well, because when the stem cells go back through and they get filtered, they actually hit the lungs and kind of get stuck in the lungs.
I've heard that's why it's good actually for COPD and lung conditions.
And then there's one other, the other thing that seems to be responding well is sepsis.
Oh, interesting.
And over in Europe, they're doing clinical trials on using mesenchymal stem cells for sepsis, because they are antimicrobial.
And sepsis is infection of the blood.
Yeah.
So like a joint goes septic, you get an infection in the joint, and then it gets in your blood, and then it's very deadly.
Yeah, it can be fatal.
Yeah. Interesting.
So they're evaluating that for antibiotic resistant sepsis, essentially.
Awesome. You got time for one more topic?
Sure do.
I'm interested if I'm saying, hey, I want to come and see you as a patient. What does that look like? First visit, second visit, lab works, what's it like to work with you as a patient?
Yeah. So two scenarios. One, there's a scenario where you're in Arizona with me in person. And then the other scenario is through telemedicine. So through telemedicine, we can work with patients who are in different states. Certain states we're not able to do it, and we're still limited in certain things that we can do. But I do work with patients both in Arizona and outside of Arizona. The first appointment is usually anywhere from 2 to 2.5 hours.
Oh man, you're going deep.
I'll go deep.
That's cool though.
And before that, patients are filling out about an hour's worth of intake forms where basically I'm just collecting as much data on symptoms, on timeline, on where you lived in the past, potential exposures to heavy metals or other, toxic agents. Just I try to get as much as I can of information so that I can review beforehand. So that way our 2 to 2.5 hour appointment is as directed as possible. Of that, about an hour to an hour and a half is talking about the current concerns you have. And we go through each one in depth. So again, if someone's just coming in with shoulder pain, our first patient appointment might just be an hour and a half. But if someone's coming in and they have low back pain, shoulder pain, they also have hypertension, they have a history of pre-diabetes, and they've got some weight that they could lose, then we're talking about each and every one of those. Even if they're just like, I just want my pain gone, I still need to talk to them about all those because all of those can worsen pain. And so we go through those. So anywhere from an hour to an hour and a half for talking, and then physical exam. If you're obviously in state, in Arizona, we're doing a pretty in-depth physical exam that will last anywhere from 15 to 30 minutes. And then it's anywhere from 30 minutes to an hour on talking about different labs that we might need or different options for starting treatment. Going through almost all my patients on their first visit are getting nutrition and lifestyle recommendations. Probably about 30% of the time, a patient, I'm recommending a baseline supplement that regardless of what lab work or in-depth stuff is going to show, a fish oil is really highly indicated and is not going to harm anything if we start without lab works and all that kind of stuff. And so we'll start with that. And then we do lab work, and then we move on to more in-depth therapies, and again, this is on the systemic side of things. So if, patients if we're doing hormones or that kind of stuff. In terms of on the pain side, usually, so after that first visit, if we need imaging, we'll get the imaging. But if not, we reschedule for the procedure, which is usually about a 2 to 3 week wait time. Unless they're flying in from out of state to see me, then we coordinate to have it done in that same week. But then they'll still get lifestyle nutritional recommendations for things that they'll start before their procedure, after their procedure, so that way we can optimize the results that they're going to get from the PRP treatment or stem cell treatment. And then they come back for the procedure and we do that. And then we just work together afterwards on their hormones, on nutrition, optimize their health from that standpoint, so that the last thing I ever want to be is a stem cell shop where patients just show up, they get a stem cell procedure, and I never see them again. Mm-hmm. Because I care more about the human as opposed to just doing the procedure.
Mm-hmm. What kind of differences do you think you provide as far as the lab testing goes? Do you do some of the eclectic lab testing, as micronutrients, food sensitivities?
I like how you call them eclectic.
Yeah. I mean, they are.
Yeah. I don't
know. What do you call them?
I guess I've never really thought of it. Specialty.
Yeah. Specialty labs. Yeah. Like like food sensitivities, micronutrient tests, some of those are controversial, but I mean, I assume there's a time and place. Do you use any of those or anything in particular you'd like to talk about?
Yeah, I use quite a bit of them. And again, it's always going to be patient specific. on what we're doing. And so if a patient comes in and I suspect that they have Lyme disease because everything is just flagging Lyme, then I'm going to look at, actually running the traditional Lyme panels that the CDC recommends. But there's a specialty lab that I use that can actually run PCR, or polymerase chain reaction, which actually looks at the DNA and RNA fragments of bacteria, viruses, and fungi. And I actually want to know, is there active Lyme, is there active Borrelia in your blood, for example, because sometimes there's issues with the conventional lab testing. Mm-hmm. Or if a patient comes in and they looks like they have an estrogen dominance, so a woman who has estrogen dominance, but her serum, her blood lab work is on point and there's no major issues there, then I might look at doing a Dutch test, because sometimes the metabolites of estrogen are what is causing the excess estrogen symptoms. And so I'll look at the metabolites in the urine to say, okay, how are we going to approach this patient specifically? So yeah, and then GI testing quite a bit. I tend to run a lot of infectious disease testing because a lot of patients with chronic pain have an underlying infection. That
like stool tests, or
combo of stool and or blood.
And so you can actually look in the poop and look at what type of bacteria you got going on there, what type of microbes and stuff. And then also, I guess you're like gut permeability, aka leaky gut tests, right? Yeah. You can kind of look at some of those.
Yeah, look at different zonulin levels or histamine levels in the blood compared with the enzyme that breaks down histamine to see if we have a functional histamine intolerance or anything like that. Yeah, the specialty lab testing is, unfortunately, it tends to be pricey, but again, it's a tool that we use when it's really indicated and appropriate. That could be the difference between a patient suffering for another 5 years or finding the reason why they're having this, this cardiovascular disease or diabetes or low testosterone that really just flips the switch.
Mm-hmm. And that's one of the big conversations, I assume, and maybe you've just done a better job at it, like talking to patients. I work outside the insurance model. Sometimes you get covered, and some of the special tests, you'll get some kickbacks and stuff. But just elaborating to people that there are some times where these things aren't necessarily cheap, but I always tell my patients, for cheap prices, you get cheap service.
Right.
And, unfortunately, when you have these conditions that are chronically affecting you, like how much money are you spending, having these GI disorders, as far as insecurities, personal life, just affecting your confidence. How is that affecting if you're in sales? Having low testosterone in sales doesn't work. Like you're not going to do it. You're just not going to do well. So especially too, if you're an athlete and you're having shoulder pain and you don't get that sucker fixed, like, sorry, you're not going to the games, or, you're not you're not taking the team to state. So
and what I've found, and this is, I think, such an untapped area of medicine, but is patients' financial priorities.
Yes.
Patients are totally fine going and getting Starbucks 10 times a month and spending $150 on that. But then when a $100 lab test comes up, they're like, I can't afford that.
Yeah.
I got bills to pay, I'm in debt. And I'm like, I truly think the next big health revolution should be people like Dave Ramsey going around and helping everybody get out of debt.
I love Dave.
Oh, me too.
Yeah.
But honestly, like the amount of stress people have from their financial situation is destroying people's health. And oh man, if I could, I think one day I'm going to have a financial advisor in my medical practice.
Oh,
to work with my patients.
That's genius. That's really genius. And two, it's kind of hard as a doctor, man. There are times, especially when I came out of school, because in school we charge like $75 or something. Yeah. And to come out in the real world, and I have a lot of debt. And I want to help people. And, again, I think the services, when I look at them, I think they're more than fair when you look at the outcome. Like how long do you want to suffer? Like people spend thousands of dollars traveling all over the world with one condition. I'm like, I could have fixed that 10 years ago,
Right.
Like how often do you see that, man? And
right.
there's a big blockage in our society about how we spend money. I had a guy, maybe he ends up listening, and I don't know, he didn't come back and see me, but he or he might still. I don't know. We saw him a couple weeks ago, and I know that he was, 7-8 figures a year. And, he was, kind of he gave one of my medical assistants concerns about, well, I don't know if I can afford that, when I know he was spending $1,000 a month on steroids on the streets. And I'm like, dude, come on, man. It's like, I don't know how this happened, that our priorities, like, you'll spend all this money on your car. You'll spend you'll spend money. You'll spend thousands of dollars. I tell this to guys with ED, like, you're going to spend thousands of dollars to go with your wife to Cabo. And yet you guys can't even get it on. Like, what kind of vacation is that, dude? Like, come on. So, but hey, Dr. Drew, I think you did a great job of elaborating on a wide variety of regenerative tools that we have. And not only that, you're doing what it sounds like a great job of getting at the whole piece. Like you said, man, we're in such a niched world now where it comes down to being able to do one thing. But, people like you out there putting up the fight for, like, hey, man, this is health. So a holistic model. We got to fix everything. You just can't just, put a Band-Aid on it and say, see you later.
Yeah.
So,
yeah. And I think that's to round this out is with my elevator speech, when patients ask, what I do is I'm a stem cell physician, an integrative physician, a naturopathic physician, but at the same time, I treat the whole person. And so if you come in and your gut is contributing to your shoulder pain, or your diabetes is contributing to your low back pain, I'm not just going to ignore that, because I'm not in this silo of I only treat your pain because I'm only a stem cell physician or whatever I'm calling myself. And so it's, again, using the tools, but really, treating the human that is sitting across from you.
You got it, brother. Hey, where do people find you, man? If they want to come out and check your stuff out at, or if they want to be your patient, what do we do?
Yeah. So I'm on various platforms. Instagram is probably my biggest and probably the easiest way to get in touch with me. That's at Regenerative Performance. On Twitter, I'm at Dr._Timmermans. YouTube, I'm on there as well. I'm started dropping more videos on a weekly basis.
Love it, man. We need it.
Yeah. Facebook as well. And then website, regenerativeperformance.com. But if someone really wants to connect and I mean, you just go to my Instagram, and I put out a lot of free content daily that might help. I know has helped change people's lives, even though they've never actually seen me as a patient. And it's powerful, and I love being able to do that. But if you're looking for more one-on-one help, then the appropriate thing is reach out to us at our clinic here in Arizona, and we'd love to help you one-on-one.
Awesome. And I'll be sure when I throw this up on YouTube and the Podbean, that all that will be in the description, so you'll have an easy time finding them. So appreciate again, that. Dr. Drew Timmermans of Regenerative Performance, thanks for being on, man. We'll do it again sometime, all right?
Yes, definitely.
All right. Stopping recording now.